You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is July 13, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, the ABCs of coding. Our presenter is Dr. Gary Gross. He's the Executive Vice President of the Joint Council of Allergy, Asthma, and Immunology.
We're going to get started for the second half of our COLA presentation today. This is Friday the 13th, a lucky day for many of us. For our second talk this morning, I'm very pleased to have Dr. Gary Gross talk to us about the ABCs of billing and coding. Dr. Gross is the Executive Vice President of the Joint Council of Allergy, Asthma, and Immunology. I'm also on the Board of Directors of the Joint Council, and I think people for a number of years have looked to Gary as kind of the guru as far as billing and coding practices. Just a plug for the new fellows. The new fellows can easily become members of the Joint Council, and I think all fellows should be members of the Joint Council. It's important, especially when you get into practice, that you have an organization that's kind of fighting for your rights as you are trying to practice. And with having said that, I'm going to let Dr. Gross start his presentation. Good morning, Gary.
Good morning, and thank you. And thanks for the plug for the Joint Council as well. I agree. The fellows can easily join. The dues is very reasonable, being free, and so it really will offer you some opportunities to look into what is ahead in the future of allergy. What we're going to do during the next hour, or perhaps a little bit less, is talk about coding, and the reasons for doing this really revolve around not so much the science of allergy, but the actual getting paid for what you do and avoiding getting into trouble. So I'm going to go through a number of different areas with you as we approach this, and the first aspect is, why do we code, and why is this necessary? And you can imagine if you were to go out to buy a product, you would want to look at the product and examine it and evaluate it and make sure that you are actually getting what you're paying for. And insurance companies, to some extent, are the same way with this service that we provide. So they want to know that the service that we provide is reasonable and consistent with what they are paying us for, and that is kind of the place that coding started. There are some areas of coding that have become important recently, and we'll look at the OIG plan. But one of the things that they want to know is not only what you did, but where you did it. And the reason for this is because the payment is different for different locations. And let me give you an example. If you were to do penicillin skin testing in your office, then you would be paid for the testing, the evaluation of the test, and you would also be paid for all of the overhead that went into the test, the needles, the syringes, the nurse's time, and so forth. But if you were to do that same testing in a hospital setting, then in theory the hospital is being paid for the overhead, and so you would only get paid for the professional component. So there's a difference in the place of service, and if you bill all of your services as if they were done in the office and some are done in the hospital, then that's not correct coding. The other thing that we need to make sure that we document in our medical records is that there is a medical necessity for any kind of test we do or any services we provide. And a good example here is if you're going to skin test a patient, then you have to show that there's a reason for that testing. You're not going to take somebody that says that they have hives and skin test them for ragweed, because that doesn't jive. There's not a lot of logic in doing ragweed testing on a patient that comes in for hives, unless maybe that they had hives when they were out playing in the ragweed. But in general, you can see that there has to be some correlation between the diagnosis that you make and the services that you're providing, and you have to show medical necessity. And they want to make sure that what you do is reported correctly. So the medical record that you have really has to be complete. It has to be legible for those of us who are still using paper, and that has to be done so that somebody coming in and looking at your records can go through and say, well, yes, they did do a history, they did do a physical examination, they thought about what was going on with the patient, they have a good assessment, they tell us what the plan is going to be, and then they sign it. So it's the old SOAP, the subjective, objective, plan, and assessment, and then the patient's name and your name have to be legible and on every sheet of paper if you're still using paper. Now you might say, well, we're not using paper, we're using electronic health records, and so that's all done for us, and that's good, but we'll look at that. We'll come back to that in just a second. This is the Office of the Inspector General work plan that I was mentioning to you, and this comes out every year, and what they do is they tell us what they're particularly interested in regard to possible billing irregularities. And the reason this usually comes about is because they've done studies over the preceding years, and they say, well, we're losing a lot of money in this particular area, so we're going to make that a focus of our evaluation of charts in the next year. And so for 2012, they have a number of different areas that they're looking at. One that just came in this year is this Incident to services, and they want to make sure that physicians are billing correctly, and that when physicians bill an Incident to service, that all of the criteria have been met to provide that service and pay for it. And a good example in allergy of an Incident to service is a patient getting an allergy shot. Usually the doctor doesn't give all the allergy shots. Usually there's somebody on staff that's being paid by the physician or by the clinic to give the allergy injections. But the doctor has to be in the office suites to make sure that that is done properly, and that the shot is being given incident to the physician's instructions and presence. And so that if shots are being given and there's no doctor around, that's not complying with the Incident to regulations. I mentioned before this place of service errors that they're looking at, because they found that a lot of bills are coming in with an office place of service when the service has actually been provided in a hospital setting, and so they're trying to make up more money by billing or by making sure that they've only paid for what they're getting, and that they're not paying twice. And then the other thing that I know you all have heard about and is in the news a lot recently is the question about opting out of Medicare. And the Joint Council has published a number of times some of the rules and requirements if you decide to opt out of Medicare and what the provisions are. But one of the provisions, if you opt out of Medicare, is that you agree not to submit any claims to Medicare, and the patients sign a contract where they agree not to submit their claims to Medicare. So what they're looking at is if a physician has provided a service after opting out of Medicare, and then either the patient has submitted that bill or the physician has submitted that bill and are trying to get paid even though they've previously opted out, so that they can have private contracting with some patients and not with others. So if you opt out of Medicare, you agree not to take any Medicare dollars, and your patients agree not to take any Medicare dollars, that it's a transaction just between you and the patient at that point in time. And I think it's a 2-year agreement that you have to provide to Medicare if you're going to opt out, that you have to say, I'm going to do it for 2 years, and then you have to re-up every 2 years that you opt out. Okay, the other area that I wanted to mention in the OIG is the electronic health record, because it is an area where a lot of people will say, well, I have electronic health records, it does the coding for me, so I don't need to worry so much about how I'm going to code, because my software actually figures out what I have done at every visit, and I'm automatically given the level of service that I'm providing. Well, again, in this situation, the OIG has said that, see, for some reason it's not advancing. The OIG has said that they are going to start looking at electronic health records, and they're going to see if, there it goes, if the electronic health records actually provides the information that they need, and that they're not paying people for things that the people are not doing. So they're reviewing the electronic health records of the providers to see if there is evidence of identical documentation across services. And basically that means cloned medical records. So if every one of your review of systems looks the same, if every one of your physical exams looks the same, then they're going to question, well, did the doctor really do the service, or is this just something that's preloaded into the electronic health records? And so they're not doing it, they're just it's just showing up. And they're also looking at the companies that make the health records to see if there is a system out there that makes it easier for you to get a high level of payment for your services when you are using the pre-populated fields in electronic health records. So I just caution all of you to try to use sensible approaches to your electronic health records. Don't do a lot of cutting and pasting. If you find that there are areas that have changed since the last visit, make sure that you document the changes and that you don't have data in the electronic health records that contradicts what you're putting in another part of the electronic health record, which is something we see frequently. The present illness will have certain symptoms, and then you go through the review of symptoms, review of systems, and those symptoms will be different in that area of the chart. So this is an area that's becoming important for the Office of the Inspector General. Okay, let's talk a little bit about coding and what all this relates to. The evaluation and management codes are the codes that we bill for our office visits. And there's a whole section in the CPT book about this. And for our new patients or follow-up patients, there are 5 levels of CPT codes that you can look at and decide to bill for depending on your documentation. All of this has to do with documentation of 3 key points, and that is the history, the physical examination, and medical decision-making. The first follow-up E&M visit is the one that you're looking at now, this so-called 99211, which is a level 1 follow-up visit. And some people refer to this really as a nurse's visit because the CPT book specifically says that this may not require the presence of a physician. And an example that you can think of in allergy would be a person who's on immunotherapy. They're getting their shots on a regular basis, but they come in one day to get their shot and they say, well, after my last injection, I had not only some itching at the site where I got my injection, but also I felt a little short of breath later, and I had a little more congestion during the day after the day that I got my shot. And so I'm not sure if it was due to my allergy shot or it's due to the change in the weather. So the nurse comes up and talks to the doctor about this, and they decide, well, just on the side of caution, we'll reduce the dose of the next shot and see how the patient does after that. So here there was an interaction between the nurse and the doctor. The doctor had some input into the decision-making, and the nurse documents all this and can charge the patient a level 1 99211 office visit, even though the doctor didn't have a face-to-face visit with the patient per se. So the patient would be charged for the injection and also for this level 1 office visit. It wouldn't happen at every time, at every visit the patient came to get the shot, just when something happened that made it necessary to have some physician input related to what the next dose might be. On the other hand, if you look at some of the levels of E&M visit where there is face-to-face input from the physician, you can see from this level 3 description, which requires at least 2 of these 3 key components. And look at what they are. They're called expanded problem-focused history, or an expanded problem-focused examination, and then medical decision making of low complexity. So for every level of service, they tell you what they're expecting in the documentation. And this particular one is expanded problem-focused, expanded history and examination, and then low complexity medical decision making. And I'm not going to go into great detail about these, but I want you to look at this and then differentiate this level 3, which says expanded problem focused, from the next slide, a level 4, which says detailed history, examination, and medical decision making. And I'm going to show you where the documentation becomes so critical if your history and physical examinations are then reviewed by a third party when they come in to audit your records. So remember, this is expanded problem focused for a level 3, detailed for a level 4. And when you look at the definitions of expanded problem focused and detailed, one of the things that you can see is that the expanded problem focus looks for a problem pertinent review of systems and no past family or social history. So you can bill for a level 3 and not have any past family or social history, but if you bill for a level 4 and don't have that documented in the chart, then the company can say you did not document enough service to provide for a level 4 history. So there are some very simple things that you can do, and we'll go through the definition of what is brief and what is problem pertinent and extended and so forth. But this points out that you can leave off something that you might have actually asked about, but if you don't document it, if you don't show that you asked about the past history, family history, or social history, then you can't document the level 4, you're back to a level 3. Okay, so if you look at the various aspects of the history, one is how many parts of the history of the present illness did you document? Location, quality, severity, duration, timing, and so forth. So there are different aspects. For instance, in this example, I used a headache. In where it is, how it feels, how severe it is, how long it's lasted, and so forth, to find out more about that headache, to get a good history about the headache for the present illness. And then you look at the review of systems, and you can see that we have a number of different systems that can be reviewed. And the number of systems that you review and that you document that you reviewed helps determine the level of that review. And then finally, the past family and social history includes those 3 key elements. And we almost always ask about this when we're seeing a patient, but sometimes it's not documented. And as I said, if it's not documented and you're charging for a level of visit that requires it, then they will either downcode you or ask you to reduce the charge. The physical examination is very similar in terms of the structure, the way that it's evaluated. They have problem-focused, expanded problem-focused, detailed, and comprehensive. So you can see that this fits into a pattern where we're having more requirements for higher-level E&M visits. And similarly, the medical decision-making fits into the same kind of pattern. The definitions or the names have been changed a little bit. So you have straightforward, low complexity, moderate complexity, and high complexity. But again, to reach those different levels, you need more information evaluated, you need more diagnoses to consider, or you need more risk in terms of the disease and the patient that you're dealing with. So you have all those variables that you have to put together to determine the level of an E&M service. And none of us can really remember them, and that is, in fact, one of the reasons that the new electronic health records are nice, because there are some programs that have the software built in that if you correctly document what is both medically necessary and what you have done, then the electronic health record will tell you what level of service you potentially can bill for. If you're not using electronic health records, then there are some other kind of cheat sheets that will help out in that regard. And this is one example where you can see at the top is the history of the present illness, the review of systems below that, and the past family and social history. And then at the bottom of the chart you have the physical exam. And just blown up a little bit to make it a little easier to read, you can see what they've done. And they've shown you a level 1 at the far left-hand side of the screen and a level 5 at the far right-hand side, and have gone through the various aspects of the history of the present illness and the review of systems that you need to qualify for that particular level of service. So if you're seeing a new patient, 99201, and you need all three, you need the history, the physical, and the medical decision-making all to qualify for that 99201, you can see that for a level 1 new patient visit, you don't even need a review of systems. You don't need a past family or social history. But if you're going all the way over to a level 4 for a new patient, for the review of systems, you need at least 10 of those systems, and you need at least 1 of the past family or social history to be in the chart and documented. Similarly, if you look at the physical exam, you can see that for a level 1 exam, you may need just 1 of any system area for a level 1, but if it's a level 5, a comprehensive, or even a level 4, you still need at least 18 from at least 9 of the different system areas that are listed. Now, before I move on, just to help a little bit with this, is that, or maybe it's going to make it more confusing, but to clarify some of the reasons that you will see some differences here, are there are actually 2 different years in which these guidelines have been published. One was 1995 and one was 1997. And in theory, if somebody's reviewing your chart and they're saying that you either qualify or don't qualify for the level of service that you build, they're supposed to use the year guideline that is best for you or better for you. And so you can use the 1995 guidelines, and there's more leeway with the physical examination in the 1995 guidelines. In the 1997 guidelines, they put out very specific guidelines for what they considered an immunologic examination, a hematologic examination, an EMT examination, and so forth. And so for the 1997 guidelines, you have to qualify on each one of the points that they've designated, whereas there's more flexibility with the 1995 guidelines. So we usually recommend that people go by the 1995 guidelines. And in general, that has worked for us. Last year, or perhaps the year before last, one of the insurance companies put out a bulletin and said that they were only going to accept documentation that conformed to the 1997 guidelines, making it a little bit harder for us to document the higher levels of service because of the physical examination. But aside from that difference in the physical examination between 1995 and 1997, most of the other parts, the history and the medical decision-making, are very similar. So medical decision... Excuse me?
Can I ask a question?
Absolutely.
The slide you just had up before this one, was that the 95 or 97?
That's 95.
Okay. Because typically we're not doing GU exams or neurologic exams or psychiatric exams or muscular exams. So
I can't imagine that.
So is there still, I'm trying to add this quickly, is there still 18 components there that we're doing?
Okay, the beauty is that in the 1995 guidelines, there was a kind of an overall statement at the end saying a comprehensive examination would also qualify if it were that which the examiner thought included every important point on the exam. So basically, they were leaving comprehensive up to us.
Okay.
And so if you're saying, if you're doing what I would call an allergy evaluation, and you do an exam of the eyes, ears, nose, and throat, and you comment on things like turbinates, mucus, postnasal drainage, TMs, external canals, skin, and so forth, that in the large allergy community, most people would agree that that is a comprehensive exam and what you need. I mean, maybe if somebody came in with hereditary angioedema and you needed to feel the liver and spleen and do more of a GI exam, that would be appropriate. But if somebody came in with allergic rhinitis, the GI exam, the muscular exam, and so forth would not be standard of care. And that's the big advantage of the 1995 exam, is that they allow that overall comprehensive exam to be in the eyes of the beholder.
Yeah, I just hope that the person looking at the chart has the same eyes as I do.
Well, the nice thing about that is if you get audited and somebody's looking at your chart and they say, wait a minute, that's not what I consider a comprehensive exam, you can say, well, I want this audited by an allergist. And so there's a fairly good chance that if another allergist audits your chart and sees the same thing that they would put, that they're going to give you an affirmative grade on that exam. So I think you're right. I think if I had a hematologist examine my charts and I said it was comprehensive, they would say it's clearly not because I didn't feel all the lymph nodes. But most allergists would look at the same kinds of things, I think. Okay.
Okay, thank you.
That's exactly what the problem is in the 1997 exam, is they don't give you that leeway with the comprehensive exam. Okay, so medical decision making is going to be about the same for both the 1995 and 1997. But if you're doing a new patient examination, you need each one of these components. You need the elements of the physical, the history, and the medical decision making to be documented in the chart. So if you have a patient that comes in with a really complicated history, or if they are hard to get a history from and they take twice as long as a patient that's well educated and has already gone to the internet and already has reviewed the websites and learned a little bit about their disease and can come in and give you all the right answers, just because it takes twice as long doesn't mean you can bill twice as much. You still have to document the parts of the exam, the parts of the history, the parts of the physical exam, and the parts of the medical decision-making that went into deciding the level of service, and that's what determines the level of service. Now, having said that, you'll notice at the bottom of this slide there's this average time for a level 1, a level 2, level 3, level 4, and level 5. But that average time doesn't relate to how long it takes you to do the history, physical, and medical decision making. That average time is used for a separate way that you can bill for your service to a patient. So if you're doing an E&M service and you're going to bill based on time, greater than 50% of the face-to-face time that you're in the room with the patient has to be delegated to counseling and coordination of care. And I had a good example just yesterday. I saw a patient a few weeks ago for chronic urticaria and had done the history, the physical, the medical decision-making at that visit. And he comes back a month later, and he has had no episodes of urticaria, fortunately, and no symptoms over the past month. And so now it's a time where we talk about, well, where do we go from here? What do we do? How do we manipulate the medications? And the physical examination was in the history were really brief, but I spent a lot of time talking about urticaria and the medications and what the future was. So I billed based on time, and I calculated, or I looked at the total time that I spent with the patient, and I knew that more than 50% was counseling and coordination of care, and so I wrote in the chart face-to-face time, 15 minutes, greater than 50% counseling and coordination of care, and you can see that for that the established patient code would be 99213, so that's a level 3 code. If I had spent 25 or 26 minutes it would have been a level 4 code. So there, the total time that you're face-to-face with the patient will determine the amount that you can bill for that patient. And it's very important for us to know these codes, because a lot of the time we spend with our patients is talking to them and telling them how to do things and how to help them long-term with their chronic problems.
Gary, I have a question regarding that. This came up. This comes up once a month for me. I'm doing a combined eosinophilic esophagitis clinic with one of my GI colleagues. We put patch testing on when we see them together at the beginning of the week, and then they come back to see me on 2 days later and 3 days later for reading of the patches. I haven't been charging for the first visit when they come back just to do a quick reading, but we charge for the second visit when we do the final reading, and I do my face-to-face time to decide, okay, these foods are positive, where do we go from here as far as counseling and such, which is basically the majority of my time is spent talking about what the results of the patch test mean, how that's going to influence your treatment and your diet, et cetera, et cetera. The physical exam is basically, for the most part, looking at the skin. I've already done the history. I got all that, a few days earlier, so that's all been taken care of. But I've, basically been looking at that as sort of a level 2 sort of thing. But the reality is that I'm spending more than 15 minutes in the room, face-to-face time, and the majority of that is counseling.
Yeah, and unfortunately for that code, that's a gray area, because the code doesn't describe what you bill for. It doesn't say, well, do you bill for the patient returning and reading the test, or are you just at the outset billing for application of the test? In simple patch testing, not necessarily for eosinophilic esophagitis, but if in metal patch testing and so forth, most of the people who talk about coding will agree that the 95044 patch test code includes both the application and the reading of the code. What you're talking about is a little bit different, because it involves a little bit more time, and depending on how long that actually takes, you may be able to bill for an extended prolonged visit code, or you may be able to bill an E&M code because your talking to them is more extensive than just the interpretation of the test, the report of the test, and then the ultimate influence that test result might have on their lives. And so there are two ways of doing this. One is to go ahead and bill the E&M visit and say it was a separately identifiable service, that it wasn't part of just reading the test, interpreting, and writing a report. And so you bill it as an E&M visit, and you modify that with a 25 modifier. That will pass for a lot of insurance companies, and they'll accept that. The other way of doing it, and this is becoming a little more common because the insurance companies are getting more strict, is that you do what we used to do many years ago, and that is we had a separate summary consultation. So it's inconvenient for the patient, but it eliminates this question about what can you bill for. So you see the patient, you do the second visit where you look at the test, you interpret the test, you read them, and then the patient has to come back for yet a third visit, which is the summary consultation. And that E&M visit is just face-to-face counseling and coordination of care. So what I would recommend is that initially you bill the E&M visit with a 25 modifier, and you bill based on time. And then if you get denied for that and you appeal and you're denied, then you explain to the patient the insurance companies do not allow for us to have this discussion at the same time that we see you for the skin test result, or we're not paid for this discussion, and so we really need to spend some time with this. I'd like for you to come back next week when we can sit down and have a more detailed discussion of what implications these are for your diet and for your esophagus.
Okay.
Okay, it's not as nice as we would like, but sadly, the insurance companies really are kind of influencing not just how much we're paid, but how we're treating people to some extent.
So, I mean, I document this in my note that we've had this discussion and stuff. Should I haven't traditionally been doing this, but should I also put on there, the actual amount of time that I spend in the room?
Absolutely. So the two things that you need when you're going to do that is you need the face-to-face time, and you need the fact that greater than 50% is counseling and coordination of care.
Okay.
And if you have those two pieces of documentation when you appeal, then you have a much better chance of winning that denial than if you don't have the face-to-face time and the 50% counseling coordination of care, because your appeal letter says this E&M code was billed based on time, is documented in the note, and so forth.
Okay.
Okay.
Thank you.
Okay. And then the other thing we were talking about just now is these prolonged service codes or prolonged visit codes. And the prolonged visit codes were originally designed for situations where, for instance, with an asthmatic, you might see an asthmatic that you know that you've taken care of before, and they come in the office and they're having an attack. And so the history and the physical isn't the major part of the time that you spend with the patient. You're really spending a lot of time treating the patient and evaluating the patient in between treatments. And so you might only be able to bill a level 2 for the history and the physical and the medical decision-making part, but then you spend all this extra time. And so you can see there these 99354s and 355s are codes that you can add on to the E&M code. And depending on whether it's a new patient or whether it's a follow-up patient, there are different levels of time that you can add on. And something to point out here is you can see, for instance, on level 3, 99213, the typical time was 15 minutes. And so the threshold or the beginning of the prolonged service starts 30 minutes after you've seen them for the visit. So you have to see them at least 45 minutes to be able to bill 99354, and then at least 90 minutes to bill 99355. But again, those are add-on codes. Those are codes in addition to the E&M visit. And if you were spending 45 minutes with a patient after you did a quick history and physical, or 40 minutes for the reading, then you could use that code as well. Okay, are we ready to move into specific allergy codes?
Sure.
Okay, so I've given you a bunch of websites, and you have the slides there, so I'm not going to spend a lot of time on the websites. I am going to mention that you need to get the ICD-9 and the CPT books every year, and in this regard, there are going to be some changes in the allergy codes, not in 12, but in 13. So there are a number of websites that you can go to. You can see some of them up here. A lot of them are government websites. Also, the AMA has a good website. I'll put in another plug for the Joint Council. And one of the websites that I use most frequently when I get coding questions is I go to Google. And it's just amazing what you can find in there. Like that 95044 code with the patch testing, I Googled that and found a lot of different coders had comments about whether you can bill for the interpretation or not. Okay, for the allergy codes, there are a couple things I want you to look at. One is that when you're talking about immunotherapy, this specifically says parenteral administration of allergenic extracts. And so you just listen to Dr. Cox talk about SLIT, and these codes don't apply to SLIT. In fact, there is no code for SLIT. I didn't listen to her whole presentation, so I'm not sure if she talked about this. But there is not currently a code to use for sublingual immunotherapy. So that's part of this. Other therapies down in the second paragraph, you can see you have to document what you're doing. You have to document, as I said before, that the diagnostic procedures are correlated with the clinical judgment and knowledge of the natural history. You have to have the package to bill for any diagnostic procedures you're going to do. You can't bill for pulmonary function testing if there's nothing wrong with the lungs. When you are looking at the evaluation of maintenance code, remember that the test and interpretation of a skin test is part of the work of the skin test. And so that test and interpretation of the skin test is not a separately identifiable visit. Okay, so you cannot report an E&M visit for test interpretation and report. That's the work that we do when we do skin testing. You can do an E&M visit, and sometimes, as I said before, on another day, if you want to go over what the patient will have to do in regard to dust control, in regard to immunotherapy, or whatever else you want to talk to the patient about. But again, there are some companies that are not allowing us to report an E&M visit on the same day as allergy testing because they say it is all combined. The CPT says that it is not, but you have to have good documentation to support that appeal. Allergy testing, we have a number of different codes for allergy testing. One of the most common ones you're going to use is 95004, which is the percutaneous test that we do on our patients for skin testing. If you're doing venoms or drugs or biologics, the same procedure is coded with 95010 for percutaneous and then 95015 for intracutaneous. Now those codes are going to be changing in 2013, so you'll need to have the new book when that happens, but right now those are the codes that we're using. And you can see that it says for 95004, for instance, it specify the number of tests, so that if you do 5 tests, you're paid a certain amount. If you do 10 tests, you're paid twice as much. And those go by the number of tests. Other tests that we do commonly in allergy, we do inhalation challenge testing, and this is the code for the challenge tests, which has to do with either methacholine or histamine or mannitol or whatever challenges you may be doing, and the entire test is viewed as the single code 95070. Remember that you also may be doing pulmonary function tests with that, and so you might also bill a 94070, which is the pulmonary function sequential testing that goes along with the inhalation challenge. So it's 2 different codes. 95075 is currently the code for ingestion challenge, and usually most commonly this is used for foods. And it also can be used for drugs. Sometimes you'll do, for instance, penicillin skin testing and then do an ingestion challenge test if their testing is negative by giving them a capsule of a tablet or a capsule or a tablet of penicillin. And that currently is billed as 95075. That will be changing in the new code book for 2013. Immunotherapy are commonly used codes, 95115 and 95117. Now, 95115 is the injection of allergen extract. So it's actually injecting it into the skin. It has nothing to do with what is in the vial or what is in the syringe. It's just the syringe, the needle, and putting it into the patient's skin. So if you do one syringe and needle into the patient's skin, you code as 95115. If, on the other hand, the patient, for instance, is allergic to molds and to grasses and you can't combine those in the same vial, so you have 2 injections, then you code that as 95117. If the patient is highly allergic and requires 3 different vials, so gets 3 different injections, you still code as 95117 because you can read there that the CPT definition is 2 or more injections. So if you code for these, if you code 95115, the unit is always 1. And if you code for 95117, the unit is always 1. And we've had a number of people ask if they can code for more units of 95117 because they had to give more injections, but by definition, it's 2 or more, so you can only code for 1 unit at a time. We actually had somebody that had to refund an insurance company quite a bit of money because they had been repeatedly charging their patients for more than 1 unit of 95117. And so they've been doing it week after week when they got shots and lots of different patients, and so they had a lot of money that they had to refund to the insurance company. These other codes are called combined codes 95120, and that's an old code that combined the professional service for giving the shot along with the antigen extract. And they're rarely used, they're not accepted by Medicare, and you would only use those if you had a small carrier, an insurance company that required you to use that, and not one of the more common codes, separating the injection, the codes that we just talked about, from the antigen extract itself, 95165. So the other code that is commonly used in allergy is the 95165, and you can read there that it's the professional service for the supervision of preparation and provision of antigens for allergen immunotherapy. And it further says that it's single or multiple antigens and that you specify the number of doses. So the way that you charge for 95165 is by the number of doses that you expect to get out of a vial. And if you have a buildup where you expect a patient to take, say, 4 shots out of the first vial and 6 shots out of the second vial and then 10 shots out of the third, then you can only bill for the number of injections that you expect to get into that patient. So that would be 20 injections, 4, 6, and 10. And if you bill for 10, 10, and 10, then again, the insurance can come back and say, wait a minute, your build-up schedule says that you're only going to give them 4 shots out of that first vial. Why are you billing us for 10 injections? And they'll ask for the amount that you charge for those extra 6 injections that you didn't give. So it's based on the number of doses that you give and not the number of antigens in the vial. Most insurance companies will pay that, and the concept of dose is that it is the amount that you inject into the patient, that you give the patient. Medicare has a little bit different guideline in terms of their payment system. And they will pay you based on the number of cc's in the concentrate vial, regardless of how many doses you get out of that vial. So remember that when you're billing Medicare, you're going to charge them for the number of cc's. If you have a 5 cc vial or 5 ml vial, you're going to charge them 5 units of 95165, regardless of how many units you actually get out of that vial. But and that would be true of anybody, any of the insurance companies that said they use the Medicare rules. But for anybody else, you're going to charge the number of units that you expect to give to the patient based on the way that you do allergy treatment. For 95170, that's whole body extract. We use that for fire ants. There's not a lot of other uses of that I know of. You all may know of some others. Venom immunotherapy is a little bit different because venom immunotherapy does go back to the number of different venoms that are in the bottle. So if there's only one venom, then the code is 95145. But if you have 2, say you have honeybee and wasp, then the code would be 95146 because there are 2 single stinging insect venoms in that vial. And again, the units would be the number of doses. You can see up at the top, number of doses. But here you're looking at a playing field that has both the horizontal and vertical grill, number of doses being one side and number of venoms being the other side. So if you have a patient who's on 5 different venoms, they're going to be billed more than the patient who is on 2 venoms, even though they're getting the same number of doses, because the 95146 pays less to you than the 95149, which pays more. And that obviously is because of the cost of the venom, and there's a significant cost in the venom. So you have to look at what your patients are getting and how much they're going to be charged for each of those particular antigens. Are you all doing rush and cluster?
Sorry, I wanted to ask you about 95180. It's Linda.
Yep.
I had actually a paper I submitted. A reviewer questioned whether we would look at 95180 for inhalant allergen and said it was limited to what you see on the slide, insulin, penicillin. But I would argue that we do use this code for rush and cluster for inhalant allergens, and I've queried people around the country, including Bob Lanier, and he agreed. Would you agree?
Well, the most common code that's used for both rush and for cluster is 95180. Now the problem
Regardless
is
of allergen, right?
for inhalant, exactly, for inhalant allergens.
Okay,
right.
Thank you.
Now the problem with that is that, as you can see from the CPT definition, they give this example of insulin, penicillin, and serum.
Right.
And I don't know anybody doing equine serum anymore. But because of that is in there, some of the insurance companies said that they will only reimburse 95180 for a CPT code that says a patient has an insulin allergy or a penicillin allergy. And so you're absolutely right. And I find this has been very limited. Most patients who are inhalant allergy sensitive and getting rush immunotherapy will have it covered by 95180. But there are a couple of insurance companies that have this more strict classification and will not pay for 95180, and in that situation you would have to bill 95199, which is the unlisted allergy clinical immunologic service. Now, and just because of the point that you raise, I think it's always a good idea if you're going to use 95180 and you have a known amount of time that you're going to have a patient doing rush or specific cluster immunotherapy, that you get prior authorization and you talk to the insurance company and you say, this is what we're doing, we're monitoring this patient very closely, this is a potentially life-threatening type of treatment that we're giving for a very good reason. But so we have to keep the patient in the office and monitor them all the time, then I think they'll probably pay you for it. But some of them want to know up front why they're paying this instead of just for an allergy shot. Okay, so always get prior authorization.
Yeah, we had that problem years ago, then it seemed to be fine, but the problem seems to be resurfacing. So we're addressing, sending literature, and we'll see if we can get it turned around.
Exactly, and that's what happens. And one of the reasons is because this gets onto the radar screen, and they see more bills for 95180 come across. They start saying, well, wait a minute, we're paying more money for this. Why is this? And they don't realize that they're saving money on the 95115 and 95117 codes. So, yep. Then we see the 95199 that I just mentioned is unlisted, which you can use for ice cube tests or other kinds of tests that you do. And then the pulmonary function test, I just want to say briefly that 94060, which we do all the time for pre- and post-bronchodilator, that includes the spirometry that you do initially. So you can't bill for a 94010 and then for a 94060 for the after. It's the pre and the post that is in that code, and it also includes the nebulizer treatment. It doesn't include what's in the nebulizer, but includes the use of the nebulizer to treat these patients. So you can't bill separately for a nebulizer treatment. 94070 I already talked about. A couple of other codes just quickly, the injection codes, because these are not IT codes, but a lot of times we will give epi, or the other thing that's an injected substance is omalizumab. And so the question comes up, well, do you use the therapeutic prophylactic injection, which is 96372, or do you use what is below a highly complex drug biologic agent, which might be 96401. You get paid more for 96401, but there are variations in insurance companies and even in Medicare carriers as to whether or not they will pay you for 96401 when you give omalizumab. So you have to, again, I think, find out from the carrier what code do they want you to use. You might have to explain to them at the outset, this is a biologic, it's a complicated mixture. We have to monitor the patient more carefully. There is an association with anaphylaxis, and so that's the reason that we think that 96401 is appropriate. But even with that, we've had some of our members turn down, and they've told us that they can only bill 96372. And there are also some variations on 96401 where some companies will say, okay, we'll pay you for 1 unit of 96401 because we can see that you have to monitor the patient more closely and you have to spend more time with the patient, but we won't pay you for 3 units of that even if you have to give 3 shots, because you're monitoring for the same amount of time and the same patient and you're using the same personnel, so we'll pay you 1 unit of 96401 for your injections of omalizumab. So again, variations, depends on the carrier, depends on particular insurance company, and you should try and find out beforehand to decide what code you're going to use. Just a brief comment about 96372. You can see that it says diagnostic injection as well. So it's therapeutic, prophylactic, or diagnostic injection. So if you're doing testing for a patient for a local anesthetic, for instance, and you are going to subsequently give some subcutaneous injections of that local anesthetic at full concentration, this would be the code that would be used for those diagnostic subcutaneous injections. That really covers it. There are a couple of extra slides here that just show you some of the new codes for 2012 for ICD-9 codes, but I just want to put these in to emphasize the need for you to get the new books. There are always going to be some revised ICD-9 codes, and the importance of this is that when a code is revised and changed, the old code is no longer good. So if you use an old ICD-9 code and there's a newer, more specific code out, the insurance company will deny that payment because you're not using a currently applicable code, and that's one of the reasons why it's so important to get new books and use the correct code for the date of service that you're billing the patient. Thank you. I will stop now and be happy to try and answer any easy questions.
Does anybody that's online have any questions for Dr. Gross?
Underneath the names, there's mute all, unmute all.
Yeah, but we don't need to usually.
Usually they raise
They'll raise it.
Okay. Does any of the fellows here have any questions for Dr. Gross? I guess we don't have any questions or any more questions. I do appreciate you taking the time to give us this talk this morning. It's always a challenge when we're trying to do billing, and especially at the beginning of the year where we're trying to teach this to new fellows and make sure we're doing everything we're doing right. So especially here we're in an institution where we have institutional charges or in addition to professional charges, so it's a little different than in private practice. But again, thank you, Gary, for taking the time to be with us. We're going to end this morning's session for Conferences Online COLA. We wish everyone a happy weekend and have a good time, and we will see you on Monday morning. Thanks again, Gary. Have a good weekend.
Very good. You too.
This has been an ACAAI production. To learn more about Conferences Online Allergy or the American College of Allergy, Asthma, and Immunology, go to acaai.org. See you next time.